This week's shout out is to our listener in Bulgaria. Sorry we don't speak Bulgarian, but thank you for listening from Sofia. Thank you very much.
Welcome to the First Principles of Medicine podcast. In this series, we will be breaking down complex medical topics into their first principle. When the stress is on and you've just been asked a tough question that you don't know the answer to, we feel you'll be able to fall back on these principles to formulate a decent answer and perhaps reason your way out of trouble. Welcome to another episode of 1PM. I'm joined around the table by a couple of new guests today. We've got Cindy.
Hi.
We've got Jaslyn.
Hello.
And we've got Jason.
Hello.
And today Jason's going to be taking us through the wonderful, wonderful topic that is pneumonia.
Isn't that wonderful?
It's high yield, guys. It's high yield.
So pneumonia, I wanted to go through today. It's a pretty high yield topic. So to understand pneumonia, the first thing I wanted to go through was an approach to shortness of breath. Okay. So I want everyone to think very broadly about shortness of breath. Okay. So what are some of the processes involved in shortness of breath?
So you can't breathe? What do you mean?
Like an anatomical approach?
Yes, anatomical approach or anatomical physiological approach. Okay?
Of classifying.
Sorry, this is more physiological approach, not anatomical.
Of classifying shortness of breath, you mean?
Yes.
Okay. Yeah,
so I'll start you off with the first one. Okay.
Yeah.
So the first process is inefficient oxygen getting into the lungs. So what are common causes of obstruction?
I guess in kids like foreign bodies.
Yep.
And obstructive lung disease,
Yes.
like COPD, asthma.
Great.
Jason's favorite one is like a bit of steak lodged in the windpipe. Isn't that right?
I remember we were practicing a heart failure station. It's like, give you differentials for acute shortness of breath. My first one was literally inhaled foreign object in a 60-year-old. And Adian was like, you didn't think of APO or heart failure?
I didn't think of anything. You thought like his mind like choked in a steak?
Yeah.
But yes, all right, cool.
Yeah, so those are good ones. Foreign bodies, especially in the pediatric population. Those obstructive airway diseases. And the other one was maybe like a pneumothorax because the oxygen can't even get into the lung if it's collapsed. So following the air going into the lungs, what's another pathological process?
Gas exchange.
Yes. So gas exchange from the alveoli into the blood or the capillaries, right? And what are some conditions which can affect that? What are some conditions? Yes, pneumonia, the topic of today, right?
Oh.
It affects oxygen transfer.
That's that's exam technique right there.
From the alveoli into the capillaries of bloodstream, okay? So pneumonia, anything else?
PE.
PE, perfect.
Pulmonary edema.
Great. Yeah, so those are the three main ones I've kind of think in my head of affecting oxygen transfer from the alveoli into the blood. So pulmonary edema, pneumonia, and PE. Now, what's the next pathological process? Come on, Adian. It's your time to shine, mate.
Oxygen from the blood to the tissues?
Yes. So there's a lack of transport of the oxygen into the tissues. And what would be some of the causes of that?
Anemia.
Anemia. Yes. Anything else?
Carbon monoxide poisoning.
It's very low yield, but sure.
Is that? No blood.
No blood. Okay. What are the types of shock? It's a type of shock.
Hypovolemic shock.
Yeah. Or just types of shock in general.
Just shock.
So septic shock, right?
Yes.
Because it affects the ability of oxygen going to the tissues. Anemia. And then what are some conditions which cause reduced cardiac output?
MI.
MI? Yeah, sure.
Cardiogenic shock.
Heart failure.
Heart failure? So yeah, those are just some general ones. I was thinking of like, what are some common conditions? So I think like shock, heart failure, aortic stenosis, and anemia are kind of the main conditions involved in that process. And finally, what's the last process? This one's a bit more obscure.
Not enough mitochondria.
No, there probably is, but yeah, I didn't
Would
think
it
of
be
it
like
like that.
your muscles and stuff? Like not being able to actually breathe because you have
Not to be a smart ass,
neuromuscular.
but technically that would fit more into the inability of getting oxygen into the lung.
Oh, okay.
I'll give you a hint. I'll give you the last process and give me a cause of it, okay? So increase respiratory drive.
Hypercapnia.
Yeah. So
Wait, what?
So the final cause of process involving shortness of breath is when you've got increased respiratory drive.
Oh, like
And
anxiety?
Anxiety could be that.
Oh, as in
I have that
independent
right
of,
now.
you mean like independent of oxygen? So
Independent.
It's caused, not caused by hypoxia.
Yeah, what are some things which cause central
Yeah, yeah,
increased
yeah.
respiratory drive? So
Yes.
anxiety,
And like metabolic acidosis.
metabolic acidosis. That's a key one, right? So DKA. So that's a nice way of really thinking about the processes, okay? So anyway, I just wanted to go through those kind of 4 broad categories to just, get your brain going, get the physiology going, because this next physiological,
It gets worse, gets harder.
this one, okay, I just wanted to tie that first year physiology knowledge to what we're going through today, okay? And that is ventilation perfusion mismatches, okay? Does that ring a bell?
Yes.
Yeah. There are 2 pathologies, right? Ventilation perfusion mismatches. What are those?
Shunt?
Shunt. Yes, that's one.
Dead space.
Dead space, okay? So now you've got a 50-50 shot, right? So with a shunt, is ventilation reduced or is it normal?
It's normal. It's not normal.
This is the question I always ask because I always get these 2 concepts confused, okay? I think an easy way to understand what a shunt is compared to dead space is think of some conditions involved with each one. So a shunt, like a classic example, is a pneumonia. So with a pneumonia, what would be the
Reduced
ventilation?
ventilation, normal perfusion.
Perfect.
And dead space is like a PE.
COPD.
So it's, I don't know,
So PE, follow that logic. Well, what would the perfusion be?
reduced. And
Reduced,
then,
right? Because there's a clot in the blood.
Yes. And then ventilation's normal.
So a classic example of a shunt is a pneumonia and pulmonary edema, okay? So shunt refers to poor ventilation and normal perfusion, whereas dead space refers to normal ventilation and poor perfusion,
Easy.
okay? And the way I remember what dead space is, and to not get those concepts mixed up, is that it's dead because it's poor perfusion.
Yeah.
So going through the definition of pneumonia, it essentially is an acute infection of the lung parenchyma, primarily caused by bacterial or viral pathogens, okay? So pneumonias, they can be classified into various subtypes depending on what pathogen was acquired. So what are the 2 kind of subtypes of pneumonia that we know?
Like an atypical versus a typical.
That's one, but I was thinking of another
you
one.
think, You think of community acquired versus
Yes.
non-community
Oh,
acquired?
right.
Yes, CAP versus HAP.
Or NAP, right?
So
Ventilator required?
Yeah.
VAP.
yes,
Yeah. VAP.
so if you're being really technical, there's community acquired pneumonia on one branch.
Yeah.
And then you got nosocomial pneumonia on another branch. And then those 2 can be broken down. Or then nosocomial pneumonia can be broken down into HAP and ventilator associated.
Bruh.
This tree diagram's getting
Nah.
bigger.
Because otherwise you can forget about ventilator associated pneumonia, but that's a minor thing. Okay. So hospital acquired pneumonia refers to, pneumonia acquired 48 hours after hospital admission, whereas ventilator associated is when you've got an ETT in your throat. Okay. So now we'll go through CAP versus HAP. Okay. Because this is a common exam question. They love asking what are some of the common organisms involved with each type of pneumonia. So going through CAP, Jaslyn brought up the typical versus atypical pneumonias, right? So what are some causes of typical CAP?
S pneumonia.
What's that? What's S pneumonia?
It's a strep.
Yeah. For our listeners out there. Streptococcus.
Mycoplasma. Oh, I think that's atypical actually.
So mycoplasma, atypical, yeah.
There's Klebsiella pneumoniae.
I think that's more HAP, but yeah.
Staph aureus.
Staph,
And
yeah,
also-
that's part of it.
Chlamydophila or something? Chlammy.
Adian could pronounce this one.
Chlamydophila
or I butchered.
pneumonia.
Yeah, Chlamydophila.
That's like atypical.
Yeah.
Haemophilus influenzae.
Yeah,
Hey,
that's
you do
great.
that. That's
But-
enough.
I think it's really important for any exam that you can just list off like 3 or 4, because I guarantee you get one question throughout your MD degree on this.
Yeah.
So the ones I've noted down for typical, so like a typical cause of a community acquired pneumonia, you got Streptococcus pneumoniae. If you ever had to remember one, I'd remember that one. You got Haemophilus influenza, Moraxella catarrhalis, and then Staph aureus, okay? And then for the atypical, you've got those atypical ones, such as like the chlamydias and the mycoplasma and Legionella.
The
okay?
MLC, you can remember?
Oh.
For atypicals.
Yeah.
Mycoplasma, Chlamydophila, Legionella.
And then for the atypical pneumonias, there's always 2 key things they chuck in the prompt.
They're like have
They've been
birds
to
or something.
Birds, fucking birds, okay?
Or
And the
like
last
cow
one?
farmer or something.
Yeah, bird owners, that's always the chlamydia
Citici or something.
citici. I was going to say pistachio.
Oh, they're-
something. Okay, citici, okay? That's the bird one. If they ever mention birds, you just write down intensely chlamydia citici or something. I can't even pronounce it. I hate that word.
pretty good, yeah.
Okay. And what's the other thing which would get your alarm
They're
bells
up in
going
far
for
north
atypical.
Queensland in the wet season.
Something about like aircon or something.
Aircon.
Oh.
Aircon for
aircon.
Legionella.
Legionella.
Classic. Okay. Old ass
Or like on a
aircon.
cruise ship or something with the aircon.
Yeah.
Yeah.
But yeah, old ass aircon, Legionella, classic. If they're recently come from India, it's always mycoplasma or like tuberculosis or something.
Hmm.
And the last one is always immunocompromised. So you always think of these atypical causes if they mention that they're immunocompromised. That's how you get those MCQ marks.
So just a quick point on what atypical pneumonia actually means. So there's a couple of different definitions, but a couple of characteristics that define atypical pneumonia include the way that they present. So some pneumonias present slightly differently to the classical pneumonia, usually more sort of undifferentiated and like systemic malaise, lethargy, that kind of stuff. And also the pathogens are more difficult to culture. And so that's how you differentiate between atypical and typical pneumonia. Quick facts. This is 1 p.m. Quick facts.
Anyway, and then if a question asks you, yeah, what are some common causes of CAP, and you can't remember those bloody bacteria, maybe you can only remember Streptococcus pneumoniae, it's always important to remember respiratory viruses because it's so much easier to remember them. Can someone give me some respiratory viruses?
Adenovirus.
I wouldn't say that's a
Influenza.
classic one.
Influenza.
I like the,
Yeah.
swine flu,
COVID.
COVID, SARS-CoV-2, right? Adenovirus, yeah, not on my,
It's not on your list then.
not on the top of the list,
on the
but,
list.
It is a virus.
I'm
Give-
sure if
give
you
it-
put it down, you probably get a mark. Maybe
Give it
the
a-
examiner would just be like, oh, okay,
Half
sure,
mark, half mark.
I'll pay you that. But
Give
yeah, I think influenza, and you can break it down to influenza
A and B.
A and B for 2 marks. But I think, yeah, the influenzas and, of course, COVID-19
Yeah.
or
You
SARS-CoV-2.
could say para-influenza.
Yes, parainfluenza, rhinoviruses.
Oh,
Yeah.
yes.
And it's important to know, so with community-acquired pneumonias, even though they love asking about what bloody organism caused it, and yeah, because it may affect what antibiotic choice, in reality, the testing of like what pathogens causing pneumonia is actually really low yield. So apparently the pathogen or like bacteria causing the pneumonia is only identified in half of cases. So I guess it is kind of useless knowledge, but relevant for exams.
For exams only. For exams only. Yeah.
So just remember that, okay? That
There will definitely be a
when
question.
you order
on
your
that.
sputum MCNS, it's very common that you don't actually get a bacteria back, okay? And now we go through hospital-acquired pneumonia. What are some common HAP organisms, okay? HAP versus CAP, okay?
Oh, we said Klebsiella.
Klebsiella pneumonia, okay?
Pseudomonas
Pseudomonas.
aeruginosa.
That's a very important one to remember, okay? Staph, because staph is everywhere in the hospital, right? I think if you're going to remember one HAP, always remember Pseudomonas aeruginosa, okay? And that's important because it's a gram-negative bacteria and it actually affects what antibiotic you'll choose, right? So if you're saying that they've got a HAP caused by a HAP, you got to be thinking, oh shit, I need gram-negative coverage, okay? But I'm no ID expert. That's what I just think in my mind. Pseudomonas, gram-negative coverage, okay?
Cool.
So I think really defining whether it's a HAP or CAP can help clinically because it can help decide what antibiotics you're going to choose, right? So yeah, they've come in with pneumonia. You want to assess the severity of the community-acquired pneumonia. Is there any famous scoring tool you would use?
Cindy, you know what this is.
Curve 65.
Herb 65, okay?
What's in Curb 65, Cindy?
Confusion. Urea more than 7. Respirate more than 30. Blood pressure less than 90.
Yeah, 90.
Age more than 65.
Great. Curb
Perfect.
65, right?
Perfect.
There's guaranteed to be an MCQ there somewhere. Surely you've been asked that before.
I swear we've never
I
been
think
asked
I've
that.
seen it as a short answer in a EMQ.
So that's a way of assessing the severity of CAP using our Curb 65 scoring. It's good to know it, but can you tell me about the scoring and what it actually means? So we start off with 1. What does the score of a 1 mean?
Mild.
But mild, but what?
It means that like you could probably treat it in the community.
Yes, right? So you can discharge them if they're in ED and tell them to, take some antibiotics at home and chill. Okay? Chillax, okay? You'll be fine.
Yeah. Come back and get sick. Yeah.
Okay? What about 2 to 3? What does that mean?
Moderate.
Moderate, yes. It does mean moderate. I'd pay
Um,
that. But what does it mean in terms of management?
So you choose the antibiotics for moderate severity. So they will need to be in hospital to get IV benpen.
Yeah, I'm not sure what antibiotics it specifies, but it just means that they need to be hospitalized, okay? So 2 to 3, you need some gen med admission, need hospitalization for antibiotics, right? And what does 4 to 5 mean?
Severe.
Yeah, you gotta go to
Wow.
ICU.
ICU, right? That's a magic word, ICU for 4 to 5, okay? So those are pretty much all the first principles I wanted to go through. So now we're going to go through a case to get the brain juices going, okay? So we've got Mr. Black, okay? He's a 70-year-old man from a nursing home who has presented to your tertiary hospital emergency department with some shortness of breath. So please take a targeted history from Mr. Black. Assume an AT assessment has already been completed. And the first thing I want you to do is just think of some of the differentials you'd write on your page. What would those be?
Pneumonia?
Yes. High yield.
Depending on like past medical history,
Yeah.
maybe COPD exacerbation, heart failure exacerbation, PE, pneumothorax, if there's history of trauma.
Yep.
Foreign body.
That's foreign
steak.
steak, mate.
Yeah.
Were you eating fucking
Yeah.
steak before? Those are the classic differentials you want to rule out, okay? A good way to think about differentials, especially with shortness of breath, is firstly, you want to quantify how quickly that shortness of breath came about, okay? And that's going to really help you rule in and rule out differentials. So the timing of onset is very, very, very important. So I want to just think of the differentials quickly if we break them down into things which cause shortness of breath within seconds to minutes. Can anyone think of those?
Probably like a PE,
Massive PE, love it.
pneumothorax.
Pneumothorax. So I'm talking about seconds to minutes.
Anaphylaxis.
Anaphylaxis, right? Very important one to remember. So seconds to minute, what causes you to like make you very short of breath quickly?
Asthma attack?
Asthma attack, great. So the ones I noted down were asthma attack, anaphylaxis, PE, tension pneumothorax or pneumothorax, and foreign body, okay? There are probably a bunch more, but I think those are the classic ones you need to know. Now let's think of the time context of hours to days, okay? What are some of those causes?
APO.
APO, yeah. So heart failure, yeah.
COPD.
COPD,
Exacerbation.
yeah. COPD exacerbation, great. What else?
Maybe pneumonia.
Pneumonia, like the topic of this
Right.
episode. I think it fits pretty well, guys. So yeah, the classic ones I thought of were pneumonia, COPD exacerbation, heart failure, pleural effusion, and post-op atelectasis.
Do you
Yeah.
ever just get a pleural effusion?
It's annoying. It's one of those differentials you can say, but it's like a complication of something else.
That's what I always think of it as.
But I think you can use it as a differential, which pisses me off because it confuses me.
Yeah.
I'm pretty sure you can put pleural effusion down as a differential. Yeah. So we've gone through hours to days. Classic one, pneumonia, you want to remember. Weeks to months. What could be the cause of shortness of breath?
Anemia.
Anemia. That's a good one.
Cancer?
Cancer. Yeah.
Heart failure,
Heart failure.
COPD.
COPD as well. Yeah. What are some lung conditions? We've probably 1+, so you probably haven't
pulmonary
learned them.
fibrosis.
Pulmonary fibrosis. Great. Yeah. Yeah. So things like that, bronchiectasis, even chronic asthma can cause shortness of breath in that weeks to months context. Okay. So I think that's a really good way of thinking about differentials with shortness of breath. And the first question you kind of want to ask when attacking a shortness of breath OSCE, right? Is it seconds to minutes, hours to days, weeks to months? Okay. So let's say now Mr. Black states that his breathing difficulty started a few days ago after feeling some cold and flu-like symptoms. He mentions that his wife also had a cold last week. So with the history now, let's just focus on the presenting complaint history. What are some things you'd like to ask for?
I'd just like to know about if he's got like a cough and the characteristic of it. Is he coughing anything up? Coughing up any
Yes.
blood?
Very important, right? Is it productive, like have you got phlegm, or is it blood, which then you think like cancer and things like that, right? So the cough, very important thing you could ask on a respiratory history. Anything else?
Chest pain.
So in terms of associated symptoms, chest pain is very, very important to ask, right? Because things like pleuritic chest pain with pneumonia, chest pain like from an MI, you still want to rule that out, okay? Anything else?
Fever?
Fever, right? Because that helps you to think of infective causes like pneumonia, right? Or if they're afebrile, you may want to think about some other causes like foreign body.
You asked about the constitutional symptoms.
Yes.
So in addition to fever.
And what is your way of remembering?
I'm a
constitutional
big fan
symptoms?
of waffle. Waffle is the way to go, guys.
Yeah.
Weight loss, weight changes, appetite changes, fevers, / night sweats, and lethargy.
And almost for every single OSCE, you could ask those 4 questions.
You should
Yeah,
ask
you
those
should.
questions.
When in doubt, ask about waffle, okay? Anything else we'd like to go through? Like, think about respiratory history. What are the
Any
Any
key
birds?
things?
Any birds?
Do you have any fucking
birds?
birds?
Been to India
Any
recently?
birds, dogs, cats?
Travel?
Put them down.
Any travel?
Work, occupation.
Yes. So work history, very important as well, right? Do you have dodgy aircon? Okay. What else is important in work history?
Gardening.
If they're like exposed to fumes and chemicals. and
Yes,
things.
right. So dust, like asbestos, like fine particles, things like that, right? Yeah. So the work history, your pets, a very, very important thing to ask. Anything else in a shortness of breath history?
Travel.
Travel, right? Have they recently come back from a place where tuberculosis is endemic? Classic thing with India,
Or like, have you been on a plane for 14
Yes.
hours?
Yeah. right?
Recent surgeries? Yeah.
Also calf pain and ankle swelling.
Yes, right. So calf pain in particular, very important to ask because that pretty much rules out a PE. But for purposes of exam, if they don't have calf pain, it's very unlikely to be a PE. Okay. And the last one, which is very important as part of the comprehensive history, can anyone remember?
Smoking?
Smoking history, right?
And vaping. Don't forget that.
Very true. Very true.
True. And with smoking history, yeah, a quick way, you always just want to get the number of pack years and whether they're currently smoking, right? And don't say, do you currently smoke? Just ask quickly, have you ever smoked? It's a way of just cutting an extra question from your history. Because if you ask, currently smoke, they say no, then you have to be like, have you ever smoked? And it's another 2 questions, right? It just got rid of one right there, okay? Have you ever fucking smoked? So now we've done the history. Can we just quickly go through some key history features for the common differentials? So I think like pneumonia, heart failure exacerbation, COPD exacerbation, and PE. Just rattle off some quick ones for pneumonia.
Just based on it, how they were presented to you on an OSCE prompt.
Yes.
If that guy's come off a plane,
Yep.
that guy's had recent surgery, is a PE. If
Yep.
that guy's been traveling, got any pets or any sick contacts, it's a pneumonia.
Yes. What about heart failure? What are some history features?
Pillows, he's living with pillows, can't lie down.
Classic.
Swollen legs,
Yeah.
it's heart failure.
Yeah, and then like a past MI in the history. Classic. COPD exacerbation.
Like functional decline, I think is a big one with
Yeah.
the chronic ones.
I swear it's just smoking. I swear if it's
Smoking.
smoking, it's smoking.
Smoke like a chimney.
If they've been smoking for like 30 plus years, bright in big capital letters, COPD, baby. It's always that, okay? And then PE, it's like calf swelling, like you said, recent surgeries, malignancy, very important.
Weight loss.
Weight loss, OCP use as well, or like the contraceptive pill. Oh, and a family history of PE or coagulopathies or whatever, okay?
Sorry, just to cut in. So, but for you, like MD3s and MD2s listening, being able to recognize these patterns actually saves you a lot of time because
Yes.
you find that you don't actually have to spend as much time reading triggers. You can just literally pick up these key points and then you can go ahead.
And it just comes with experience, I think, because you just see the same like
Yeah.
practice questions or whatever and OSCEs. You're like, you can just pick it from a mile away. Oh, you recently traveled, you had some cold and flu-like symptoms and your kid was sick in daycare and you've come back and given you a cold, right? Yeah, so it's really important, as Adian said, to kind of just remember those brief, quick prompts for the classic presentations, okay? Now, you've done your history. I want you to please outline relevant targeted examinations you would perform and what signs you are looking for in this patient based on the history.
Okay, so with every exam, I would start with a general observation.
Yes, I love it.
See if the patient's alert, well or unwell, and any
Yes.
distress, and then get a set of vitals,
Perfect. That's the general exams done. Now, specifically, what would you like to do?
a respiratory exam.
Yes.
So I would like to have a listen of the lungs and have a tap of the lungs.
Yeah. So, yeah, there's always a way of describing respiratory. And then what's another exam you may consider doing?
Cardiovascular.
Cardiovascular, right? If you get that, you're doing well, doing very well. Okay.
Mm-hmm.
And now just quickly going through those 4 conditions again, what are some classic exam signs? So you can say, to be a real smart ass when you're doing your exams, be like, for the respiratory exam, I'm going to be looking for signs of pneumonia, such as coarse vocal crackles, dullness to percussion, and increased vocal fremitures. Okay. Those are just some fancy signs of a pneumonia, right? So what are some classic signs of a COPD exacerbation?
There'd be tripoding, potentially
Yep.
resonant on percussion with like sort of reduced chest expansion and a wheeze on auscultation.
And another one is like a hyperexpanded chest, cachectic, pursed lip breathing. These are just like fancy things you can add onto your OSCE. They're not essential, but if you can just quickly blurt them out, being like for pneumonia, I'm just going to look for crackles as well as dullness to percussion. So next one, heart failure. What are some classic signs?
Edema, peripheral pedal edema.
Perfect.
Might see raised JVP.
Yep.
They might be propped up on some pillows.
Yeah,
They might have
perfect.
some oxygen on them.
Yeah, third heart sound, bibasal creps. Those are things which will be in a prompt, like once they give you the exam findings, or you may have to just briefly mention in an OSCE. And last one, PE. Anyone think of any?
Might be a swollen calf.
Yeah, swollen calf.
Tachycardic.
Tachycardic, yeah, great.
Normally, I think on the exam, it's pretty normal, right?
Yeah, except I think you can get the pleural friction rub, which I have no idea. No idea what that sounds like, but if I really wanted to press that internal med position, and if I could actually remember on the day, I would say pleural friction. I have no idea what it actually sounds like, but I can say it, okay? So it's really useful to just know some classic signs for each of those to sound really smart in an exam, or to be able to recognize them if they give you the exam findings, okay? And now we've done our exam, the prompt then continues asking, can you please list some relevant investigations you would order based on the history and exam? So let's say it looks like a pneumonia picture. What are some investigations you'd like to order? Starting off with bedside.
Actually, that's a very good point. If you're asked this in an OSCE, a good thing to say is I would start with some bedside, like break it down, like signpost to the examiner that you know that there are a bunch of investigations that can be done at different stages.
And what's the logic with going like bedside first?
Oh, because it's right there at the bed.
Exactly.
Get it quickly. Get
It's
help.
quickly.
Get it
It's quick. It's cheap.
It's easy.
Save money. Taxpayers' money done. Doing some quick bedside investigations.
First one, always want to do ECG. Always
Yep.
want to rule out some kind of ACS. You want to do, if indicated, urinalysis, for example. Get a blood sugar level and a ketone level.
Fancy one I think of is like a COVID-19 rat as well.
Oh yeah, the rats. Yeah,
But that's
yeah.
like, yeah, real fancy. You're not
Yeah.
going to fail if you don't get that. But with the bedside investigations, there's literally only like 6 or 7, and then they're always the same. And you just pick and choose which ones you'd like to do, or whichever ones are relevant. And for ECG, what sign are you looking for PE?
Cindy, what are the ECG changes?
S1, Q3, T3.
What is that?
So an S wave in lead 1, and then Q wave and T wave inversion in lead 3.
Nice.
But commonly it's just sinus tachycardia.
Usually just
Yes.
tachycardia. Yeah.
But you can have features of right heart strain as well.
Mate, perfect. That's a 6 out of 6
Oh,
on
is
that
it?
exam. That PE one is just one of those classic things you have to
Yeah.
remember. It's not super relevant clinically because I think sinus tachycardia is by
Yeah.
far the most
Yeah.
common thing, but you probably get one exam question in your life.
It's almost just used for exams.
Yeah.
It's literally just, are you a HD student or not HD student?
Or are you really good at just remembering stupid stuff? Okay, so you've done your bedside, you've done your ECG and your COVID-19, right? What are some bloods you'd like to do?
I'd want to do a blood gas
Yes,
in any patient with shortness of breath.
perfect, right? And so a blood gas, so VBG. And what are you looking for on the VBG? Or what do you expect?
Well, in someone with pneumonia, probably not much. They might have a raised lactate if they're septic. But I guess you'd be looking at their acid base balance
Yeah.
to see if they're in any respiratory.
What does a pneumonia?
Acidosis.
Yeah.
Yeah.
So a pneumonia typically causes a respiratory acidosis, right? So you'd have a reduced pH, the CO2 will be raised, and you may see hypoxia or low PO2. Okay. And then you'll judge the metabolic compensation. Is it partial or full, whatever. Okay. But respiratory acidosis is the classic thing you would see on a pneumonia. So that's very important to remember for like an urgent blood test. You want to do a VBG because it kind of tells you how unwell they are. What are some general blood tests we'd like to do?
So you can always say these for almost anything you order for. You can do a full blood count because you want to look at
Yeah.
signs of anemia or any raised infective or inflammatory markers.
Perfect.
You want to do a UEC to check their baseline kidney function.
But what are you looking for in
But you-
UEC, which is relevant to pneumonia?
What?
You mentioned UEC for baseline,
Yeah,
but
yeah,
it's
yeah.
particularly important for pneumonia
Is it?
Really?
because what's on a UEC, bro?
Urea. Okay,
Urea, right?
Plus all the other stuff.
Yes. So urea is very important because urea greater than 7 is one of the criteria for CURB 65. And so continue. What were you saying?
The rest of all the stuff in a UEC.
Yeah.
LFTs, because not necessarily relevant to a pneumonia picture, but you probably just do it anyway because it's
Yeah.
the same tube.
Because there are other things like cholestatics.
Yeah.
Good be-
CRP.
CRP. Yep.
If you're worried about sepsis, do blood cultures.
Yes. Very important.
If you're worried about, is it still an ACS chest painy thing, you might do troponins,
Yep.
or heart failure, you might do BMP, or if it's like, I don't know,
Chef's
pancreatitis,
kiss,
do
mate. Perfect.
amylase, I don't know, all that kind of shit, right?
That's great. That's pretty much all the blood tests you have to do. And remember, just try to categorize in some urgent blood tests like BBG, particularly important. And then those general bloods, as Adian said, the full blood count, UEC, LFT, CRP, BNP, troponin. Like, and I think BNP and troponin, if you consider like a chest pain in particular. Okay.
Some exam hacks here, guys. If you're asked to write investigations and you want to write the bloods last and list out the bloods, because sometimes markers, they just treat all your blood answers as one mark. So if it asks for 3 things, for example, and you write FBC, UEC, LFT, you might only get 1 mark.
As you can tell, Adian's like overthinking this
No,
way too much.
this is exam technique, guys. This is exam technique.
It's
We
smart.
were not taught this until like a month before our exam. So we're telling you now.
That is a good point,
It's a good
especially for written
strategy.
exams.
Hacks.
Not for OSCEs, but
the
for written, it's
writtens.
very important. For OSCEs, you definitely want that bedside bloods order
Mm.
before going to imaging.
Where I
But
think if you're going to write bloods down in a written, just write the ones that are the most important or special. Like, I
Yes.
think blood cultures would count separately from your basic
Yes.
sort of
I hope so.
And then micro, what are some micro tests we'd like to do?
sputum MCNS,
Perfect, right? What else?
urinary antigen.
Viral PCR.
Perfect, yeah, viral PCR, because
Urinary antigens. Okay, Jazz.
Yeah.
urinary
Urinary
antigens, that's a
antigen.
flex answer, as I like to say, right? So what urinary antigens are you looking for?
Pneumococcus.
Yes. So pneumococcus is actually streptococcal pneumonia,
Yes.
apparently. Like, I don't know
Yeah.
why it's called pneumococcal. It's like the pneumococcal vaccines for streptococcal pneumonia, just for fun fact.
Because it's streptococcal
'cause
and
the-
it's a pneumonia.
But
I never,
pneumonia.
it took me so long to realize that strep pneumonia was pneumococcal. Like, I thought they were,
Do you know what meningococcal is?
but yeah, I think the classic ones you definitely want to say sputum MCS, viral PCR, because they're actually done all the time in ED.
Yep.
And then if you're real fancy, as Jaslyn is, you want to do, the streptococcal urinary antigen assay. And then if you're suspecting atypical, you want to do the Legionella one. Okay. So micro done. Now we move on to imaging. What imaging would you do?
CXR,
CXR, right?
chest X-ray.
And Adian, I want you to tell me, what is the classic description of a pneumonia?
On a chest X-ray,
Yeah, on a chest X-ray.
you might see an area of heterogeneous opacity, usually in a lower or middle zone that would be consistent with consolidation, that in conjunction with the clinical picture is likely pneumonia.
Whoa.
Beautiful. If you can do that, though,
Chef's
There you go.
kiss.
There you go.
chef's kiss,
You don't
right?
have to see it, but if you know it's pneumonia, you
Yeah.
just say that.
And a few things when describing chest X-ray, especially for an OSCE, you always want to describe what it is, and then you say, in conjunction with the clinical picture is likely a blah, 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 blah. And from my experience, you can almost guess what the chest X-ray is going to show
Before
from the
they-
clinical
yeah.
picture. So don't get overwhelmed thinking it's going to be something unexpected. If it looks like a pneumonia based off the history, it's likely going to be a pneumonia on the chest X-ray, okay?
It's obvious. Like
Yeah.
in that respect, they're usually not trying to trick you.
Yeah, and just learn those keywords. So like, is it unilateral, bilateral? Is it homogeneous, heterogeneous? Is it focal or is it widespread? Okay, and that will get you through most X-ray interpretations. And then any other imaging you may consider. I don't think these are important, but you can consider these.
Anything, guys?
Maybe a
got-
CT
CT
chest.
chest.
Yeah, so I think
It's
CT
not
chest is
resolving.
sometimes done, especially if you're thinking of like an interstitial lung disease or something like that. CT chest I've seen clinically. I don't think it's too important for an OSCE. I just thought I'd throw that in there.
Yeah.
And then there aren't any like special investigations. Okay. You'd only maybe consider like a pleural fluid analysis if there is a pleural fusion. Okay. So now we've done our investigations. We've done it in a nice systematic way. We've gone through our bedside bloods, micro imaging. We've now gotten our investigation results. Okay. So the OBS, you find out that the patient's febrile, their rest rate is 30, their blood pressure is 120/80, and their oxygen saturation is 90%. On exam, you find crackles at the right base and dullness to percussion at the right base as well. On the bloods, there is raised white cell and CRP, and the urea is greater than 7. And on the sputum MCNS, it picks up streptococcus pneumoniae. And on imaging, there's a right lower zone, homogeneous
Whoa.
opacification. So can you please outline your management of Mr. Black? What would you start off with? Let's say you're still in ED.
My
right?
A to E
A
assessment.
to E, yeah. For this patient, they don't appear super unwell, right? So you can probably just use that as a throwaway statement. Like, I'll just quickly do an ADE assessment to ensure they're hemodynamically stable. Done. Ticks to the examiner. Oh, safe doctor. Has a structure. I like it.
Yeah.
Okay.
Very good.
Now we're going through management. What are some of the non-medical management things you'd like to do?
Position the patient.
Yes.
Educate them about what's going on right now.
But position them how?
Ah, yes. Position them upright.
Yes.
Yes.
Upright, right? It sounds stupid, but I guarantee there's something on the marking scheme saying them position them upright because you actually can ventilate better when sitting upright. You want to get them to do some deep breathing as well, get them to move around if possible, because that probably helps with atelectasis. But those are just some words you can throw around. I would encourage a patient to sit upright, move, do some deep breathing, and I'll get some regular nursing obs as well.
Oh, yeah, yeah.
Bang. Non-medical, done. 10 out of 10 on the global, baby. Okay. Now, medical, the fun part. Okay.
Yeah.
What are some things you do for medical management?
Give antibiotics.
Oxygen, if he needs it, is set to
Yes.
low.
And those two things are the mainstay, right? I think most people can say oxygen therapy and most people can say antibiotics, but a simple thing to remember is always simple analgesia and simple antiemetics to make sure the patient's comfortable.
Mm.
And with oxygen therapy, what are some targets you'd usually aim for?
Above 94, well, unless
Yeah.
they've got COPD.
Yes. So the classic things like, you want to aim for greater than 92% or 94% oxygen for most people if they've come in. And then for COPD, what is the special number range?
Between 88 and 92.
Yeah, just say it. I can't be bothered going through the physiology.
Doesn't matter.
Cindy
Doesn't
may die. And now we go through the empirical antibiotics, okay? Usually I hate learning antibiotics, but I think this is one of the rare conditions you probably should know it. However, if you can't remember, just say this simple statement. I would start them on empirical antibiotics based on current guidelines.
In fact,
Done.
you should say that regardless of if
Yes.
you do know it or not.
Yeah.
You
You
What a
should say that.
would
safety
double
net,
check
your
with the
own
guidelines.
answer.
You would always say
Yeah.
guidelines.
So if you,
Always.
to cover your base and to actually show the most competence, you want to say, the antibiotics for this is da 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 da, but I will check with guidelines.
Yep.
Done.
Yep.
Okay. And now the empirical antibiotics. So for low severity CAP, which this patient could be, what would be the empirical antibiotics?
Oral amoxi and doxy.
Perfect. So I think for the amoxicillin dose, it is 1 gram TDS. Now for moderate severity, what are the empirical antibiotics, Jaslyn?
IV benpen
Perfect.
plus oral azithromycin. Is that right?
Doxycycline.
You've
Oh,
chosen
doxy.
wrongly. Yeah. So it's benpen and doxycycline. Okay. And then for high severity,
Kef
Kef and what else?
and azith.
Kef and Azith. Yeah. So these guidelines probably change every 6 months or year or vary depending on where you're from. But in Perth, this is what they currently are. So for low severity, we've got, once again,
Amoxicillin plus doxycycline.
moderate severity
Benzyl penicillin plus doxycycline.
and high severity.
Ceftriaxone plus azithromycin.
Beautiful. Absolutely beautiful.
Unless they're allergic, you can do that stuff. No, you gotta check the allergies.
Fuck, allergies is good. Yeah. Always in the history, check allergies. Yeah, you give him cap, dead. Failed OSCE. Doesn't matter. Doesn't matter what.
Anaphylactic to
Doesn't matter if you
penicillin.
said simple analgesia and antiemetics. They're dead now because you've given them penicillin.
Oh, no.
No, but really, it's very important whenever you give antibiotics, especially penicillin ones. It wouldn't surprise me that they actually have a penicillin allergy. And in that case, just say you refer to ID for specialized antibiotics.
Mhm.
And then for HAP, what is that one principle I want you to remember for hospital-acquired pneumonias?
Pseudomonas.
Pseudomonas,
Gram
right?
negative.
Yeah. So for the purpose of exam, I'd choose antibiotic which has gram-negative coverage, and I'll refer to the ID guidelines. So just remember that keyword, gram-negative coverage. For simplicity, it's just really important to know the CAP ones.
Yeah, makes
Okay?
sense.
If you're being real fancy as well, you could say I would order regular CRPs as a marker of their progression, like once they're admitted. And then what are some things you could consider as part of your medical management?
Refer to physio for chest physio.
That's just showing off.
They pass the exam, that's why. You know.
You forget to check for allergies, but you remember contact precautions, right?
You're protecting yourself, not him. VTE prophylaxis if they're in.
What are some things you consider? Yeah, DVT prophylaxis, any patient admitted, you could always pretty much say that. What else?
Monitor vitals.
Yeah, monitoring nursing obs as part of your non-medical management, always good to mention.
Give them some fluid.
Yeah,
You need some
IV
fluid?
fluids based on their fluid status, right? Maybe Mr. Blackie's not eating much because he's been coughing up yellow gunk, okay? Maybe thirsty. And the last thing, can anyone remember? This is more clinically like they do, but I swear steroids are always given. or steroids are commonly given for pneumonias or COPD exacerbations. So you can always just say, I consider some steroids if indicated, especially with COPD exacerbations.
Yeah.
Okay, surgical, there's nothing. But
Lobectomy. Cindy can do it. She's a cardiothoracic surgeon.
Are you really?
I wish.
and then to really show you're a safe doctor and to really get those good marks, okay, we want to add on the DFS, right? The disposition, follow-up, and safety net. So for disposition, what would you say?
Well, depending on their curb 65.
There you go.
Perfect.
There
I
you
love
go.
it.
Didn't fall for the
Yes. Okay, and now that I'm testing whether you've actually
Well,
listened,
Mr.
what is their
Brown.
curb 65? I've given you all the results. What is it?
Is he confused?
No,
So I think it's 3.
it's 3. Yes. So based on that prompt, the score was 3 because the patient's age was greater than 65, their rest rate was 30, and the urea was greater than 7. And what does that mean in terms of disposition?
So he needs to be admitted as an inpatient
To where?
to the ward.
Yeah. Well, you can just
Gen
say
Med what?
respiratory
Under
rod,
Gen Med
AMU,
or
Gen Med.
respiratory, yeah.
Instead of saying the ward, right, you can just be a little bit fancy.
That shows you've been to the wards.
So classic ones, you can always say AMU or
AMU.
Gen Med because
They take everyone.
Gen, it's just
Yeah.
general, right? And then in terms of GP follow-up, okay, imagine that they've been treated in the hospital for a few days and they're on the mend. What would you tell the GP to do as part of
Thank you for seeing Mr. Black. Thank you for your ongoing care of Mr. Black.
Yeah.
He was recently admitted to whichever hospital
Yes.
for community-acquired pneumonia. He was given this antibiotic.
Yeah.
I don't know if he's given anything
Yeah.
home, like he was discharged with antibiotics, but recheck his bloods.
I think the point I wanted to get across, like, what are some preventative health things you would
yeah,
tell the
Vaccinations?
patients? Vaccinations.
Smoking
What are
cessation.
the main vaccinations?
Influenza, COVID, and pneumococcus.
Perfect. Okay. So that's really, if you want to get those marks, right? You just mentioned you'd encourage your patient to get those vaccines, COVID-19, influenza, and pneumococcal because you've got a background of COPD or blah, 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 blah. Okay. And Cindy, you mentioned lifestyle advice. It's
Yes.
always the same, but what are they? Give it to me.
Smoking cessation, alcohol reduction, and optimizing diet and exercise.
Perfect. And the fancy one, which you can always say.
cardiopulmonary rehab.
Yeah. Don't know what it is. Don't know what to say. Always mention it. If it involves the lung or the heart, cardiopulmonary rehab. Okay. But yeah, quitting smoking is very important, especially for COPD.
If
Okay.
they never smoked, you just congratulate them and say, continue not
Yeah,
smoking.
continue not smoking.
Not
Yeah.
smoking.
You can always comment on smoking
Always
regardless.
gotta say, there's always a tick
Continue
about
to not
smoking.
smoke. They're 70 and never smoke. Continue not smoking, bro.
Good job, bro.
And lastly, safety netting. Okay. So you've discharged them now. What safety net advice you would give them for the ED and for the GP? Because you don't tell them to always rush back to ED. Sometimes
Yeah.
you can tell them go see their GP instead, right? So what are some specific ED safety net like advice you'd give?
If you notice yourself becoming more short of breath, if you notice any chest pain, you notice any fevers,
Perfect.
or you're otherwise concerned, please present to your ED.
Great, right?
But-
And then what are some GP things you could say?
The same, but less severe.
Yeah. The classic one, I think, like more realistically, would be like, oh, if you feel like your symptoms are not proving still, like maybe because they're just on the mend still, go back to your GP and maybe they have to change their antibiotics or something.
It's always good to say, just see them in a week's anyway, just
Yeah.
to check up.
Oh, and I think for antibiotics, it's usually there's some discharge. You can say like for pending sensitivities.
Yeah,
or
step
something.
you down or whatever.
That's
yeah.
if you're real fancy. Okay. Real fancy. And that's pretty much it. You've got 10 out of 10 on your OSCE now.
Woohoo.
Okay. And because you've done so well, the examiner now is like, I'm actually going to give them a 20 out of 20 instead of 15 out of 20 for doing everything perfectly. Okay. And they're going to ask you, what are some complications of pneumonia which you're concerned about?
You're going to make fun of me, but death.
Death. When in doubt, death is always out, right? It's up there with the physical deconditioning and
Should be a
anxiety.
top.
Technically it is,
Should
but
be a top.
you know, it's one of those complications you can't fix, unfortunately. We haven't figured out a way to manage that complication.
So you
I
got to
don't know.
prevent it.
Yeah.
Oh dear.
Other than death, because we try to avoid that.
Sepsis.
Sepsis.
Empyema.
Sepsis is very important, and we've done an episode on that. It's a cheeky plug. And what's a classic complication pneumonia to mention?
Parapneumonic effusion.
Parapneumonic
That's what I
effusion.
just said.
That is what you just
Did
said.
Yeah,
Said empyema.
you didn't hear it.
But it didn't sound like parapneumonic
Well,
effusion.
empyema is a severe parapneumonic effusion, right? Empyema is pus.
Yeah, but
True.
empyema is technically not a parapneumonic.
True.
Empyema could be caused by anything, technically. But anyway, the classic one is parapneumonic effusion. And we do go through pleural effusion in one of our previous episodes. so-
Another plug.
Another plug, baby. Come on, another
You
plug.
lined it up.
Look at that collaborative learning, right? Like
Yeah.
bringing back all the knowledge together, okay? So to summarize, the processes involved in shortness of breath, you've got insufficient oxygen getting into the lungs, and then you got poor oxygen transfer from the alveoli into the blood, and then you have an inability to transport that oxygen in the blood around the body, and lastly, you've got increased respiratory drive due to a systemic cause. But thanks. Thank you all.
Thank you. Thanks,
Thank
Jason.
you.
Thanks for listening. Tune in next time.
We can't
Like,
force people
follow,
to tune in.
subscribe.
Yeah, we like that. We
Give
like
them
that.
some more listens.
Yeah, and listen to our previous episodes, guys, please.
Yeah.
Yes.
No, but thank you all for listening. See you next time.
We're really excited to be collaborating with Becky from Becky's Notes. Becky's Notes bring together all the key topics medical students need to know in a readily available place, reviewed by specialists in the field. These visually striking notes are a refreshing change from all these boring textbooks out there. You can check her out on Instagram at Becky's Notes 01 and support her at the links below.